Hello, everybody. We're going to go ahead and get started again.
Okay, good. And wing
Not
it.
at all.
Not at all? Okay,
I
perfect.
always think for these things, we don't go too far because kids can
Okay.
look up our bios.
Perfect.
Just a housekeeping item. I did reach out to see if we could lower the blinds. Unfortunately, they said that if we tried, they might fall on somebody. So we can't do that. But I did try. Yeah. It's very 305. But we'll go ahead and get started. Thank you.
Great. All right, everybody. So good afternoon. So Steve was supposed to introduce our next speaker, Dr. Sylvie Naar. And, one of the things I learned with this provost job is that you get to wing things every once in a while. And so this is one of these situations where haven't really prepared, haven't even really looked at these remarks. So I'm just going to go ahead and wing it if that's okay, Dr. Naar. So Dr. Naar is a distinguished university professor at the University of Florida. Oh, did I mess that up already?
State.
Florida State. Oh, I apologize. I'm at University of Florida, and it was all about the Gator Charm
Yeah.
there. So I did actually know that you're at FSU. And she's in the College of Medicine in the Department there of Behavioral Sciences. She's the founding director of the Center for Translational Science there. She has done a lot of work across we had the one slide yesterday showing from intervention development to efficacy, effectiveness studies, and implementation studies. And her work has really spanned all of those different areas. She has been incredibly involved over the years and had leadership roles in the Adolescent Trials Network. In fact, I believe that this is where you met my dissertation mentor, Isa Fernandez. And the two of them have been great colleagues and friends since then. So with that said, help me welcome Dr. Naar, that's been just a pioneer, not only in implementation science, but intervention development, HIV, and so it's really great to have you.
Thanks. So let's see, do I touch the screen itself to begin, or are there other? Oh, you want me to use this? Okay, got it. All right. So I'm going to talk to you guys today about a series of studies around implementing motivational interviewing, but also new directions in cultural humility and anti-racism. As in my mind, that's one of the post-it notes that is related to equitable implementation science. So I have a lot of objectives in a short period of time. I want to talk to you about tailored motivational interviewing, which is how we've tailored motivational interviewing developmentally, as I primarily work with adolescents and young adults, but also culturally. Talk about work in terms of implementation of motivational interviewing. And, I started out almost accidentally in implementation science because there wasn't really workshops and institutes to attend when I started this work. And a lot of the work was very traditionally grounded in really child mental health in a lot of ways. We're some of the earliest pioneers. And so I had probably at least 3 or 4 failed grant attempts in this space before I kind of moved into an adolescent trials protocol at an NIMH R34. So I've been through those tribulations of trying to do real world science, and so happy that now, implementation science is coming to the forefront. So I'll present to you some findings of a full-scale effectiveness implementation trial, the first in adolescent young adult HIV, and among the first, I think, in terms of implementing more of a behavioral kind of intervention. And just so you know, it's because I think I got started so early that I was able to get to this place now at this point. And then talk about how we're, integrating motivational interviewing with an anti-racist multicultural orientation, and then leave you with some new system science approaches to implementation science as new directions. In between, because I'm an MI trainer, we'll have a small interactive activity, but you guys have been doing that now during the day, so it'll be a little different, but that'll be fun. So what is tailored motivational interviewing? So first of all, we've tailored MI for youth HIV settings in several ways. We've done developmental tailoring based on communication science studies, developing theoretically and empirically driven training, cultural tailoring, and then specifically developing tailored video examples with the community. And I want, so many people kind of say, oh, we do motivational interviewing, we know motivational interviewing. There's a lot of levels to understanding motivational interviewing. And just like any innovation that you're implementing, various levels to the degree to which you're implementing it. So for us, MI principles, I think a lot of the work we do is based on MI principles of supporting autonomy and collaboration and partnership. But when we implement MI as an evidence-based treatment, we're really looking at the micro level. So looking at, the communication almost at the level of each individual word or utterance. And true motivational interviewing as an evidence-based treatment is at that micro level. So that's something to think about as we move through. The other thing is I think we'll touch on implementation models and methods, although again, you've had other talks, but I'll kind of show you how some of the implementation frameworks can be utilized not only to address your sort of barriers and facilitators and mechanisms and outcomes, but also as a framework for the implementation strategies themselves. So you'll see a little bit of that as we go along. So in terms of developmental tailoring, some of the things that we think about are understanding motivation from a developmental context, understanding language from a developmental context, prioritizing autonomy support. I should argue that this isn't just for adolescents and young adults, it's probably for everybody, but it's especially important in the adolescent and young adult developmental periods. How do you manage counter change talk, which seems to be elevated in adolescents and young adults? So statements against change or statements for the status quo. And how do you leverage developmental priorities in terms of peers and identity development? So those things kind of came together in our series of motivational interviewing with adolescents and young adults. Then we talked about communication science tailoring. So how do we tailor MI from a communication science perspective? So in some of our early studies, and this is what you could consider some of the more formative work, is we actually had young people, and this was done in Detroit, where they carried recorders throughout their clinic visit. And we coded all of their interactions with physicians, nurses, and these were interdisciplinary teams. So there were also psychologists and outreach workers. And then we coded what was the thing that the provider said and what was the very next thing that the patient said. And in that process, we could glean out what were like the key kind of MI strategies that led to motivational statements and what were the strategies that led to like amotivational statements or against change. And in that way, we hoped that we could take all this MI stuff and kind of hone in on some of like what were the core components. And also, these at the same time, motivational interviewing is sort of changing across the editions and the decades. So everyone's like, well, I know motivational interviewing. I know ORS. ORS left us like 2 editions ago, actually. So there's, when you have an evidence-based treatment, it doesn't stay static, right? It changes over time, and those changes may be relevant to your population, and they may not be relevant to your population. So just to give you an idea of some of the things that we looked at, so this is an example of very specific communication statements and how they lead to what we call change talk. And then I'll show you how this influenced our implementation strategies in terms of our work with providers. So closed-ended and open-ended questions to elicit change talk actually were related to change talk. So already, while open questions probably gave you richer change talk, it doesn't mean that all that work of like, no closed-ended questions, that might not be the #1 thing that we focus on. So that's just kind of one example of how this might differ from typical MI training. Reflections of change talk led to more change talk, and affirmations do lead to more change talk, but maybe not as the #1 thing if you look at the kind of percent of variance accounted for. Then when you look at counter change talk, well, look at this. Reflections of ambivalence actually led to more counter change talk. So most of you guys who learn MI learn about reflect. But actually reflecting everything isn't a good thing. And that's really humanistic therapy. And sometimes kids, at least the kids I work with, get annoying. You have to really selectively reflect. So this is kind of another, this kind of shows you again how communication science can help with tailoring. And then if you ask about counter change talk, like what are some of the cons of taking medications, you're going to get a lot more counter change talk. Now, what are some barriers that we could overcome? That's kind of a different kind of question. So you can see that like attending to like the nuances of language and the spoken word really can lead you into different outcomes. And again, you see at the bottom, reflecting counterchange talk leads to more counterchange talk. So similarly, around commitment, what we call negative commitment language, which is really the strongest amotivational language. I will not do this. I don't want to do it is counterchange talk, but I will not do it is negative commitment. So what does this mean? This is just, again, I'm not trying to get you to like understand all the data of all these studies, but understand the process. So this is some formative work that led us now to our implementation strategy around provider training. What are we going to focus on? Well, we're not doing ORs because the first thing you learn is what you hang on to. We know that. So if we start off by teaching reflections, what we get is people reflecting everything. Instead, we start off by what is change talk? How do you recognize it? How do you elicit it? And how do you reinforce it? So that's the how we start the tailored motivational interviewing approach. We don't do reflections in response to counterchange talk because that can actually reinforce it. Instead, we respond with empathy, autonomy support. We have a technique called stop, drop, and roll, which is basically, if you hear a counterchange talk, stop what you're doing because whatever you're doing isn't working and try something different. But emphasizing autonomy comes up a lot as a really important way of managing counterchange talk and as a general approach. So MI principles talk about autonomy support, but not really how do you train it? What's the language you use? So some of the things we do is we emphasize autonomy with you statements, which is like, it's really your choice how you want to make this happen. It's up to you. This is your plan. So we used to say, like, this is our plan. Like, we came up with this great thing. Like, no, you came up with this great thing. So it's kind of switching your language to support autonomy. And then we were able to infuse our training with some specific examples from these recorded interactions so that we could actually have like real world examples from real transcripts. So that was some formative work that used communication science to inform our implementation strategy. And you'll see a lot of different methods to do your formative work, qualitative, quantitative, and then this is a different example. So what else informed our tailored motivational interviewing training strategy on how we get this MI really up and rolling in adolescent and young adult HIV? So we also wanted to use sort of basic behavioral and social science and translate that into implementation strategies. And, you know, communication science is one example, organizational psychology could be another example. In the educational world, there's a lot of methods around skill acquisition. And so we said, okay, what can we take from that basic science of skill acquisition? So we looked at cooperative learning environments, which is a specific tool to increase learning amongst groups that looks at positive interdependence and individual accountability, social and interpersonal skills, group processing. Those are all the things that sort of would inform an MI training approach. And again, like when you're writing a grant, it looks really good to show very specifically what your formative work is. Is it qualitative? Is it community engaged? But it could also be from the basic behavioral social science, educational science, etc. We also pulled from behavioral skills training so that every activity within TMI included modeling, verbal and behavioral rehearsal, and feedback. So those are, you know, just two examples in addition to the communication science on how we move towards developing this tailored MI approach. And we also have very focused loops around training and fidelity, not just the initial workshop, but the supervision. Everybody will say like, oh, everybody got, you know, once a week of group supervision. Well, what did that actually look like? Because I don't know about you guys, my supervision has been very diverse. Let's put it that way. So we try to standardize what the supervision looks like, because when you're doing implementation science around provider training and, you know, strategies, it needs to be able to be replicated by others, right? That's rigor and reproducibility. So we had an empirically driven assessment, practice, and feedback. So we had a fidelity measure called the MI Coach Rating Scale, which you can look up. It's an alternative to the MITI. It's a little bit quicker. And each item had a relevant coaching activity. So we actually had a coaching manual that said, like, if the if your provider scored low on XYZ, do these potential activities. And so that gives you a sense on, you know, how kind of formalized these loops are in an implementation science framework. So just to remind people that fidelity to innovations and evidence-based practices, especially things like MI and CBT, it's hard. So in our study of 10 adolescent HIV clinics in the Adolescent Trials Network, every single clinic said that they had done MI training, every single one. So this is not a MI novice group. But if you look at, based on our coding tool, look at the percent that actually achieved advanced competency. And we don't necessarily expect that, you know, because another question you'll think about is how much do I really need? How much is enough? Well, usually these cutoffs were developed using different item response theory methods, but advanced is for people who want to move on to be supervisors and trainers. So we're like, okay, that's not a big deal. But intermediate is our cutoff in our clinical trials. Like if you don't hit intermediate, you're not cleared to see participants. And the percentages of folks that hit even intermediate competency were very low. And not surprisingly, the psychologists and social workers tended to be higher, but still not high enough to be considered delivering this evidence-based practice with fidelity. And so we initiated an effectiveness implementation trial. We did have an R34 first that we published on, but this is the full-scale trial. So I'm going to show you how one implementation framework was used not just for my qualitative studies like pre and post, but actually to guide the strategies. So in the exploration phase, this is based on the EPIS framework, which is Greg Ahrens and colleagues. And so his framework, most people there's a big focus on the inner and outer context factors that are associated with successful implementation. It's very similar to CFIR, but he also talks about phases. And so the inner outer context factors may play out differently in the different phases. And so in the exploration phase, you're supposed to be working with the community to even figure out what innovation you are going to implement. And the ATN sites in this exploration phase chose MI as the evidence-based practice. They could have done, you know, Connect to Protect was one of their community-based interventions, could have been CBT, it could have been, I'm trying to remember, like Brother Save Brother, Saving Brother. I mean, there were so many out there in terms of EBPs, but this is what they chose because they felt that it could affect the largest range of behaviors because MI was not based on just one, like just PrEP or just condom use or just medication adherence. Preparation phase is where you work with your implementation sites to prepare for implementing the evidence-based treatment. And so what we did in this phase is we formed implementation teams at each of the 10 sites that had to be made up of a physician, a nurse, and a what we called paraprofessional staff, because these adolescent HIV clinics relied heavily on HIV testers, advocates, outreach workers, all different names for what are community health workers now. Implementation phase is when they actually got the implementation strategies, which were focused mostly on provider training. At this phase, you'll see in our later studies we did more, but people got 12 to 18 hours over 1 year where they had an initial workshop, and this was face-to-face, this is pre-COVID, but the follow-up coaching was all done virtually. And the initial workshop was 10 hours, and then they had 2 coaching sessions afterwards, and then they got these quarterly fidelity assessments and would get feedback on their assessments. And if their scores were intermediate or advanced, then the coaching was like optional. And if their scores were beginner or novice, and then the mighty, by the way, they call it below competency. That's not very good for practitioners to hear. So beginner and novice, and then intermediate and advanced. Then it was a mandatory. At the same time, we continued implementation team meetings so that the sites would then have a facilitator. This actually was Dr. Fernandez, who Lily was talking about before, and who would work with the sites around what are some of the barriers and facilitators. You know, if people weren't showing up to the sessions, why or why not? If what were some of the factors that were getting in the way? And then we actually had a sustainment phase. So after this 1 year, the sites were randomized to internal facilitation where we would then train one of their folks to be an MI supervisor and they would continue the process, or a communities of practice where we were like, here's a manual of activities, good luck. And that was kind of what the sustainment, it was a re-randomization. All right. So I just talked you through the formative work on how TMI was developed. I've talked you through the EPIS framework and how it guided the implementation strategies. Now you can see a beautifully complex stepped wedge design for a full-scale trial. So each block, and this is published, so feel free to like borrow it and use it. To, you know, you can. There's a million different ways to look at stepped wedge designs, but basically, you got 5 blocks, 2 sites per block, and each site is randomized to the intervention every 3 months. So the baseline phase varies by block, and so does the sustainment phase, but everybody gets 12 months of implementation, and this is a pretty classic randomized stepped wedge design. I'm going to pause there just to see if you have questions on what that might look like. Imagine the actual, I hate using the word implementation twice, but the actual rollout of a study like this. Keep that in mind. Staffing, timelines, every 3 months. Does that mean plus or minus a month? Plus, you know, like what are your data collection windows? Those are all things you have to think about in a stepped wedge design. Another thing that you have to think about that is very difficult for sites is a long baseline window. What does it mean to be 15 months in baseline kind of waiting for a potential intervention? So those are all things you have to think about in a stepped wedge design. Okay, so we were very excited that the implementation strategy worked, and our primary implementation outcome, this was a hybrid trial, not design. I've been reading the updates. This was a hybrid study with a stepped wedge design. You guys did you get that yesterday? Okay. Hybrid study with a stepped wedge design. And because it was a type 3, primary outcome was implementation, which is your MI competency, which was measured with the Motivational Interviewing Coach Rating Scale. And what you can see here, basically, with the stepped wedge, the way you graph it is that you just show the average over the different windows, but it's randomized. So it's not a pre-post, but the average looks like a bump up, basically 1 competency level, and then pretty good sustainment over here. And this one shows you the probability of being in the intermediate or advanced range. Remember I told you intermediate and advanced means that you were, in our clinical trials, clear to see participants. So you could see very few hit intermediate or advanced, and then during the implementation window, it jumps. But by the way, look, 50% only at the end. So again, not even with the 12 to 15 hours, not everybody is super duper at MI, but we don't know yet how much is enough. But the good news was the sustainment was not horrible. I mean, usually, you know, because of the structured, I think, training and coaching approach, the sustainment was pretty good. Now, one thing I want to tell you, there was no difference in the sustainment randomization between the internal facilitator or not. This is extremely interesting from an implementation science standpoint. We always think that training people inside the organization to continue the work is the best way to sustain it, and it's not true necessarily. One of our sites, maybe even 2 of our sites, were like, we don't even have someone, sorry, you know. So even though they're randomized to an internal facilitator, they could not find someone who could set aside the time to be that supervisor. We've just trained Department of Health and Family sites across the state, not in a research trial, in a service trial. And same thing, you know, finding people within the organization that can have the set aside time to do it doesn't always work. So we thought that was just a very interesting implementation science finding. So these have been published, and then hot off the presses, about to submit, we actually are finding effectiveness outcomes. This is at the clinic level. So not even like, this is not consented participants. This is using electronic health records across the clinic, looking at the randomized phases. And what we are finding is these are significant, though small, improvements in the percentage of detectable viral load with implementation and sustainment being better than baseline, but not different from each other. And for CD4, we actually see statistical significant changes across the 3 windows. Again, very small changes, but you're looking at implementation like training providers and then looking at health outcomes at the clinic level, which is just very rarely done. So we're very pleased to see this. And this is a very rudimentary approach, but these are all done with pretty complicated trajectory modeling analyses. So let me pause for a second. We got the EPIS framework and how we designed it. We've got the stepped wedge trial. You've seen now some of the outcomes. And again, my goal is not for you to memorize outcomes about TMI, but to kind of show you what this looks like if you actually get to go from beginning to end. All right, so then what did we do? Then we wanted to look at potential mechanisms of implementation, like why did some sites do well and why did some sites not do so well? And this is something you can all write into your grants, whether it's qualitative only or mixed methods. So we did post-implementation qualitative interviews based on the EPIS inner and outer context factors of all the providers within the site who had participated. And we basically, we did a lot of interviews, more than we could handle in terms of analysis. So what we did is we looked at high, medium, and low competency sites, and we compared the highest competency sites with the lowest competency sites to see if we could see what made the difference. So then we were able to get this down to 43 interviews instead of the large numbers that we had. And this has also been published. And so just to give you a rough idea, we actually did open coding. We did some coding based on the EPIS framework, and then we went in and did some open coding in case there were factors that we missed. And what we basically found was that when the whole team participated, you know, this wasn't like just like, oh, you mental health people do it. When the whole team participated in MI, when there was supportive leadership, not just, yeah, go ahead and do it, but actually doing it alongside with them, like doing their coaching, getting their feedback. And when the sites had fewer challenges and resources. I mean, we had sites, I hope I'm not insulting anyone, but we had sites like St. Jude, which were like private, very well-funded hospitals. And we had sites like Brooklyn, SUNY Brooklyn, that literally went into an all COVID trauma hospital at the end of the trial. So big differences in challenges and resources of these sites. That created an organizational culture that really supported EVP integration and competency success. On the other end, in terms of staff attitudes, you could see that when staff were kind of intrinsically motivated to do this versus like, yeah, we got gift cards, but it wasn't enough, that made a difference in whether they moved ahead with improving their skills and integrating the EVP. Response to feedback and coaching. So, you know, this feedback just doesn't make any sense, so I just quit. I mean, we got that. Versus, you know, it was hard, but it was good to kind of figure out what I'm doing so I know what to work on, you know, so there was like really this approach to feedback that you could see really made a difference in the high performing sites and low performing sites. And you know, these could be all related. This is qualitative, not quantitative. A problem solving approach, like this is taking a lot of time, but we sat down and looked at our clinic schedule and we figured it out, versus like, this is just too much of a problem. We can't do this. And then perceived benefits. There was just some very beautifully rich stories on the benefits of MI and what they saw after they did training. You know, I had a client who before training, this is what our interactions like, and then after training, this is what our interactions were like. And all those things really made a difference. So these are some things now that make us think, what can we do to add implementation strategies to address these things? You know, do we need to do some work individually with providers around their own intrinsic motivation? You know, what can we do with leadership? So these are kind of now take you to the next step. What implementation strategies do we need to add? Right. So I'm doing good on time because I talked fast. So the next steps for TMI now are we are testing some digital health versions of the tailored MI because it is so hard to implement with full fidelity, even in these adolescent trial network clinics, which are overall higher functioning than some of, and have many more resources than our community sites. So when we see community sites, it's like even tougher to get people to come on board. So through digital health versions, we can have centralized delivery. And now instead of training 180 providers, we can train 5 and see if we can get interventions out that way. So that's one. Another study is the Young Adult Centered Health Force training. So after I'm trying to think of when this was like right when COVID was hitting, and I'd had like, or maybe it was like in the year after, and I had like 2 or 3 grants that scored in the 40s. I'm like, oh, I'm never gonna get funded. What am I gonna do? So I went back to my youth advisory board and I was like, where should we go from here? And, they knew all the studies we'd done, and they said, we really need to do something about testing. We have self-testing, but most of us don't want to do it. We go to these clinics and they treat us horribly. We don't want to go back. And this is a big problem. So we got funded and we're just in the middle of this now for a type 2 hybrid where we looked at 42 testing sites in the epidemic counties. This is in the EHERL1. And we use the EPIS framework similarly, the way I described with the exploration, preparation, implementation, sustainment, where we work with the sites in each of those phases. And the primary outcome this time is mystery shopper assessments. And what this does is 2 things. One is it takes the burden off the provider. We no longer have to call providers and get them to do standard patient interactions and give them feedback, because that takes so much time on the provider and on our, you think that it's hard to recruit and retain youth. It is not easier to recruit and retain providers. I can tell you that. It is just as hard. So maybe you can find them. That might be the only difference, but getting them, to follow through on things is difficult because they're extremely busy. So by doing mystery shoppers now, we don't need the provider to do anything. We go to them. The second thing is it truly is youth-centered. Now it's really not just the provider doing a standard patient interaction getting coded. It's the youth going on with, describing their experience. And the mystery shopper is developed by Jose Bauermeister. So there's several domains that are related to developmental and cultural tailoring, but we've added some as well to get specifically around some of the motivational interviewing and cultural humility components. Yes, please.
How does the mystery shopper assessment work?
So this is for HIV testing. We have not found a way to do it for care, for treatment. So you go in and expect anonymous testing. You don't give your information and you get tested. And then after the testing, you report. Now,
I was curious about how it worked for care. Yeah.
Have not figured that out yet. I'd like to consider it with primary care potentially. I know there's some, like Robin Miller does some of it in Africa, but I'm not sure yet how to do it with care. So yeah, it's prevention.
It's hard with such long waiting lists for primary care. It's kind of not really a workable model.
You'd have to find people who are already patients and pay them to do it. And that's also tricky because they already have relationships with providers. And so that's kind of my next phase, is to look at that a little bit more. And then ethically, like you said, with the wait lists, it's really tricky. Now, let me tell you something, which is so sad. We are having huge problems with Florida testing sites not accepting anonymous testing, turning people away. It's a CDC requirement to do anonymous testing, and even the Florida Department of Health sites. And they're like, yeah, we know. This is what they tell us. So, we're having huge barriers to doing the study, but yet also like critical information about why Florida has this horrible HIV epidemic. We cannot get, I would say 70% of the sites are turning people away because they will not show identification. Now, and now imagine, of course, now you have, immigrant populations. It's really a problem. So some of our mystery shopper data is not missing. It's just like, turns us away, 0, you get a 0. So that's going to be interesting as the data come through. And our primary effectiveness outcome will be the number of young sexual minority men tested. I don't want to say criminal, but it's almost criminal. These sites have all these testing numbers, and when you actually look at who they're testing, it's not good. Yes.
So just out of curiosity, when they are turned down at the site, do they go back to a different?
So we tried all that.
Yeah.
But what happened was, even one of our mystery shoppers was so compliant. They're like, oh, be sure first ID. And then 3 days later, they went to a different site and they're like, oh no, you just tested. So if you give ID now, they're tracking you across these different testing sites. So that doesn't work. Yeah. I mean, I'm not even gonna tell you what it's like trying to recruit mystery shoppers in Florida with all the trauma, you know, that these young people are going through. I mean, at this point, we've recruited some in Tallahassee that literally we have to fly them around because we can't get people willing. And it's stressful. You gotta get tested all the time, you know? But we're making it work. We're making it work. So this is the next steps for TMI. I'm gonna pause, and then if there's no other questions, move on to more of the cultural humility, anti-racism components that we're trying to include. Yeah.
You kind of moved over it pretty quickly, but
Yeah.
the fact that you hit viral suppression and CD4 with the MI intervention, that's just amazing. Just unreal.
Yeah. Yeah.
We have
At the clinic level too, like not even, you know, like at the individual level. Yeah.
and this is based on data from every patient at each clinic.
Correct. 10 sites, over 1,000 patients. Yeah, over 1,000 patients.
That's
Now, our clinics are small, not huge, you know, I think St. Jude's in Detroit, or, well, it wasn't Detroit, it was some of the bigger ones. Some of the sites, like even Miami, their adolescent HIV clinic has like 80 to 100, right? So, but yes, this is with medical records.
And did you have any data on reach, provider reach?
Meaning?
How many providers you were able to engage with the MI?
Yes, so it was roughly, well, it was an N of 151 across 10 sites. Yeah. We have a separate paper you can look up on implementation completion. That varied, like whether they actually followed up with all the coaching and all the standard patients. And we actually looked at some of the organizational factors that predicted, like baseline interviews and how that predicted the implementation completion. Yeah.
We have implementation trials trying to increase pharmacotherapy for smoking cessation and HIV, and trying to increase uptake of brief alcohol intervention for people with problematic alcohol use with HIV. Both requiring provider to engage with our materials and to follow some protocols, and we have such a hard time
It's very
getting
hard.
providers to engage.
And it's even now, again, Adolescent Trials Network sites, many of these sites have been around a while. I've been around a while. They know me. I know that, you know, I mean, that makes a difference. Isa Fernandez has been around a while. She's doing this, you know, facilitation. When we tried to do this with community agencies in Orlando, like it was even even less. So it does make a difference, you know. I mean, and now with the mystery shoppers, again, now we're talking about 42 sites across the state who, you know, they kind of know FSU, but trying to get them to engage is a whole nother level of difficulty. And on top of it, now we actually met with the Florida Department of Health. We've had to, so outer context factors, right? These sites are afraid to say that they do LGBTQ specific work because it's against FDOH policy in the state of Florida. So we had to change all our materials from sexual minority men to key populations. All of our emails, which our emails are public record, right? Like they're afraid to get emails from Florida State because your emails in Miami are not, but ours are because we're state institutions. So all these are outer context factors. And, you know, believe me, I called up Chris Gordon, who you're going to meet, be like, just so you know, this is what's happening, you know, but at least we're doing it and we're documenting it, you know, and that's really the important thing. But, you know, I do think more of this work is really important, and adding these strategies, because provider training is one level of strategies and all these other ones, you know, are at the individual provider level, at the outer the organizational level, and then the outer context level. It's hard work.
And increasing adolescent adherence and increasing their engagement in care, or getting them hooked up to ARTs, ARBs. That's the mechanism you think was driving these?
Yeah, well, I think the motivational interviewing around, right, engagement with care, behavior change on the part of the individual in terms of taking medications has got to be it. Yeah. We were trying to look at retention and care in terms of appointments. It's real tricky because COVID hit in the middle of all this. And so I'm not sure we're going to be able to really look at that data accurately. People were not tracking telehealth well during that period of time. but the medications and, you know, there's things also that we don't know, like stress, you know, like MI, we know like an MI approach reduces stigma. We've shown that, perceived stigma, depression, we've shown that. So there could be other mechanisms as well, but those would be the primary. All right, are we ready to move on to a little bit of cultural tailoring? Okay, so from an, I'm not gonna go into, I have a whole video on cultural humility versus cultural competency. If you don't have it, if you haven't seen it, you can email me. But the idea is that you can't be competent in every culture. I mean, look at our Miami clinicians see not just how many languages and cultures, but level of acculturation. You know, I was born in Haiti versus I was born here. So too hard to be competent in all cultures, but humility is an approach that seems to, you know, be able to cut across some of these cultural barriers. But with MI, we need to know, how do you actually demonstrate that in language? Not only because that's the way we express ourselves, but also for coding and measurement. So there's more than cultural humility. For those of you who are psychologists, there's a whole school of multicultural orientation framework, which focuses on ways of being with diverse clients. And there's actually 3 pillars. And I'm not going to get into the weeds. We do whole trainings on this, but just to give you an idea, cultural humility, which is around self-reflection, self-critique, and mutually respectful relationships and partnerships. So it goes a little bit beyond just the MI, because you have to also really look into yourself. But there's also cultural opportunities. How often do you miss opportunities to explore cultural identity? Because, you know, most of us aren't trained on how to do it. And oftentimes it's uncomfortable and we're afraid to make assumptions. But everybody that we interviewed in terms of our youth formative work said it's the elephant in the room. Like, you're not asking me about what it's like to be Black and gay and living, you know, in Jacksonville, Florida, for example. So we're exploring, how does this look like in language? And we're not there yet, because I'm going to show you some examples that are not great, but they're a start. And then cultural comfort is the practitioners. And there's, by the way, there's are measures for each of these things in the psychology literature, but how comfortable the practitioner is in terms of the feelings that arise before, during, and after culturally relevant conversation. So those are the 3 pillars of a multicultural orientation. But again, they're not highly specified. So integrating them with MI is one of our approaches. I should also say that in some work done by Christy Gamrell and Gary Harper in Detroit, which is a primarily African American community, there was a lot of talk about MI being too white and too straight. And that's because anyone who was trained in the early years, like every video was like white and straight. There's a little bit of Native American influence from the New Mexico founders, but so we have been doing trainings, so using these approaches. So hold on one second. Okay, so what I'm going to ask you to do is, we're not going to have time to break into groups and do it, but I'm going to show you a couple of, actually, no, I think I am going to do it, because I'm not going to have people have to speak out loud. What we're going to do is I'm going to show you a couple of video examples. And then just to the person next to you, or in threes, I want you to just talk for a couple minutes about what you liked, what you didn't like, and how you might do it differently. Okay? Because these are not perfect. And what I'm going to tell you is that our youth did create these scripts. It's still, for me, some of the language still doesn't feel quite right as a provider, because you've got what the youth want to hear, but then you also have your own comfort. So for example, one of the youth things were like, oh, tell me about your family values. Families, and like, I grew up in an administration where family values were like, oh, family values is like very right way. Like, I did, so that word was not comfortable for me. And I had to figure out like another way to ask about your family's background, or how does your family, you know, what your family thinks about HIV influence your blah, blah, blah. So you have to come up with what the youth want to hear, but also what's comfortable for you. So let's see if we can. So here's an example of a cultural humility video. That's an example of cultural humility, avoiding the expert trap. All right, cultural All right, I can share this. In MI, you're supposed to be specific, which I was. It's great to hear that you are proud of who you are, but that when I heard that it's great to hear, it just was like, oh, I sounded like a cheerleader. Anyway, listen to yourself. It's really very humbling. I'm gonna play the third one and then have you guys just get together for a few minutes. So those are like little stabs at attempts. Talk with your partner next to you just for like 2 or 3 minutes, what you like, didn't like, how you do it in your own work. And it doesn't either as clinicians or as researchers. And I'm not going to ask you to share it with everyone else.
I know. But like, being like also, you know, right, which is like, but that like that's what we. I'd be like, yeah, like oh, that's not me.
Okay, another minute, just to whatever else you want to touch on.
I've also seen different parts of larger organizations, but they don't come to many.
Hey. So, the idea for this is to just start thinking about cultural humility, cultural opportunity, cultural comfort within your implementation intervention. We're not anywhere near a place where we can say, this is the way to do it, or this is the way to say it. I mean, even the questions, you know, like the questions about what else should society do? Like that gets a little bit on like minority burden, like is it really his job to say? But then other people will say, well, some youth have an easier time talking about it kind of as outside themselves versus like internal. So again, no right or wrong way, but just a way to start thinking about it. My partner, who is one of the people in the videos, is working on a book on integrating the multicultural orientation with different therapy and counseling approaches. And so he's thinking a lot about anti-racism and how that plays a role, because race is more than a culture. And so some of the things that anti-racism adds, which we're playing with, and I'm not gonna, it's a whole separate training, but is again, exploring racism potentially. And again, in MI, if the person's like, no, that doesn't affect me at all, then you're like, okay, you keep going, but at least giving a space for that. Understanding, deep understanding of historical and systemic factors that are the root cause of inequities. Yes.
One question,
Yes.
and this is kind of like, not necessarily for you,
Yeah.
but for like everybody in the room.
Yeah.
Because we've been like kind of tap dancing around this issue.
Uh-huh.
And as a Black woman, right, I see anti-racism and having discussions on anti-racism as us having an out and not talking about the anti-Blackness that happens in every single ethnicity, every single culture, right? And so if we keep whitewashing it, then we are getting ourselves off the hook as PIs, as clinicians, as physicians. And we are then in turn burdening the people that we say that our research is supposed to help. And so I'm asking, how are we being helpful if we are not talking about the proverbial elephant that's in the room? Because it's in every room. It's in this room, right? We've avoided talking about a fundamental thing, which is like, what is equity? This is an equity-focused implementation science session. And this is the second day of our session. And of all the sessions, I've only had one presenter who's literally, right, you're bringing it into the room, right? But I've only heard one presenter who has literally infused equity into everything. It's not been an adjunct. It's not been an add-on. It's not been oh, here's what we do. And oh, by the way, if you want to do equity, this is what you want to do, right? Why are we not leaning into the discomfort?
That's exactly right. I mean, they talk like, the book White Fragility and like building racial resilience. Absolutely. People are so uncomfortable. We do training. We gotta just start with that, like getting people even comfortable talking about, Blackness, colorism within every race, but also privilege, different types of privilege within race. And so that's something that, for me, I thought I was doing equity research because I was studying marginalized populations. Like nobody else was, so I'm going to go do this. And now I'm in equity. That's not equity research. It's really looking at I mean, I think this next one's also a little bit about this of understanding historical systemic factors as the root cause, thinking about socially engineered trauma and minority stress in every interaction. I got the sense you were talking about even more than that.
Bigger than that, this is
Yeah.
more of a macro, I mean, even how we come to everything that we do,
Yes.
right?
Yes.
There is a constant dismantling of who we are. So whether you're talking about intersectionality, whether you're talking social justice, whether you're talking equity, these are all interrogations of power, right? Who has power? Who's allowed to have power? When are they allowed to have power? Who's the one who's saying you can have power to say this or not? Who is being silenced or marginalized?
Yeah.
And why not? And why are we allowed to take them off the shelf and make money off of their marginalization? Because that's essentially what we're doing, right?
I mean, how do I
We're
mean, I
making
think
money
about, right, and I
as
think,
researchers often a marginalization, and I'm not saying,
oh, I feel this every day. I mean, look, I drive, like, well, not anymore, I got rid of my BMW for a trade, but I've had a BMW. And driving it, like, to these sites was a horrific, like, imbalance for me that I have to think about every day. I don't have an answer to it, but I think
Yeah.
that this perspective starts with that internal process of like, what is your privilege? What are your values? How does it play out? You know, my partner like has this whole thing like, you know, just having a Black husband doesn't mean that you understand what it's like being Black, you know, like all that. I mean, you just have to be willing to have the humility to address all that. That's the only foundational place that I can think of. I do like the concepts of allyship. I think that there's a whole literature on allyship that we can think about more deeply as a way of being, you know, in this space. So those are just extremely important points. And we don't do that self-reflection piece enough, you know, in our work. Yeah.
Well, and just to amplify this, because you and I were
Share a
talking
little
about
bit
this
more about-
earlier, I appreciate you bringing that up in this way, Fern, because what we were talking about earlier, like if you don't have people in the work that you're doing who are saying stuff as directly and sort of critically and reflectively as you just did, like people aren't telling you the truth, or you don't have the right people in the conversation. So.
Well, I'm gonna share with you another method. I mean, I'm a researcher, so I just keep trying to find more methods to try to get at this, which is, you know, that's the only thing I know how to do other than also reading and, you know. But I do like this quote, you know, because it is not light that is needed, but fire. It's not the gentle shower, but thunder. We need the storm, the whirlwinds, and the earthquake. You know, small solutions like are something, and I'm not going to stop you from doing them because every little bit counts, but it's more than that, right? We need something transformative. So again, I'm preaching to the choir, but all the things that we think we do to address this are not evidence-based. I'm just going to say that straight out. I can give you my slides later. Reviews upon reviews upon reviews that are not showing outcomes. We try here's an example of systemic change. Okay, we're going to do patient-centered medical homes and everybody's going to get this and everybody's going to get that for equity. And again, even, you know, within those settings, people of color have lower odds of receiving, you know, the full implementation of the model. We do have a transformative R01 that's trying to get fundamental new insights using system science. There is this NIH Director's Transformative Award that typically goes to omics and heavy duty, you know, advances in biomedical sciences. And we were lucky enough to get one of these awards to try to address anti-racism, not in HIV, but in general primary care. So this is in progress. I'm just going to show you a teeny little bit of it, but it's to actually try to map racism in provider behavior and organizational systems practice, with the idea that it's part of our society, it's part of everything we do. It's not an attitude of an individual provider. Identify target points for potential disruptive anti-racism interventions. So this is another kind of formative approach. And then you can actually simulate the impacts of different potential intervention strategies on the entire system. We also need new outcome measures, and we don't really know how to measure outcomes related to racism, anti-racism, other than the end outcomes of mortality, early mortality, and the horrific kinds of violence experience. But we don't have like good measures of like the mechanisms in between. So very, again, quickly, because I can share all of this. This comes from the American Academy of Medicine's community engagement model, where they actually have benchmarks, published benchmarks for each of these pillars. So community engagement is not just having a community advisory board that reads all your protocols. There's actually, very specific things that you can do as benchmarks, like, developing mutual trust, measuring that, amongst your community partners. So we have a model that we've mapped onto intervention, strategy development, and testing. But the American Academy of Medicine has been working on, measurements for each one of those pillars, community engagement pillars. So this is the model we use in that R1, and then we are using a qualitative system science method, which is called group model building, where you use specific prompts and activities, you can get trained on this, to start to map out racism in healthcare. And the idea is that it will get, it's a more formalized qualitative approach that utilizes the community. And so, again, I'm just going to give you like a picture of what this work is looking like, but we describe and map the complex dynamic systems. In this case, our focus is racism in primary care. It could be stigma, it could be PrEP uptake. You identify leverage points in that map where interventions can happen, and then you prioritize them with the community. And then later you can actually simulate them and say, if we fix this, this will happen. If we fix this, this will happen. I haven't gotten to the simulation part yet, so I'll tell you more. So for example, we have two primary care sites in Tallahassee area, which is the Deep South, for those of you who know Florida. And these are, communities that have been part of the Deep South and still are, every day. And the community-driven problem statement, so the communities were providers and residents, both, okay? Because remember, you guys talked earlier about, like, you have to define who your community is, but providers are a community in and of themselves. So it's providers and community residents or patients. At this point, we're focusing on these two healthcare systems. So we're not including people that are not in primary, like in any care at all. That's a whole nother community that needs a voice, but that's not this initial focus. Substance use disorder screening and referral was chosen by the community partners, providers, and patients as one of the primary targets. Diabetes is the other one. And you can see that the statistics in North Florida are horrible in terms of substance use treatment. And so this just gives you an example of what group model building is like, where you try to, again, develop these more complex systems maps. So not linear relationships, but really looking at the interplay across all the systems. And it gives you something like this when you're done. This is, again, I'm not trying to get you to see the actual data, we're going to publish this, but just you can see that it tries to get at the more complexity of a whole system, so that we can say, if we change this, what happens? If we can fix that, what happens? That, and then you can also model different subcomponents of the system. So that's just an example of another kind of approach to formative work that tries to get at many more of the drivers of health equity and inequity. Here's another example of some of the more complicated maps that you would draw and simulate. And then we also get intervention ideas from the community and from the providers, but some of these places may not have interventions yet. So that's the other thing. It'll tell us, like, here's where, if we could change this variable by 10%, it's a massive impact on the system, but there's no interventions here. So now what do we do? So it kind of just gives you a way of prioritizing where to head next for a community. Here's some examples of what the patients did say around substance use. And again, you could see that there's things that are not really different from what you would imagine. So what happens next is really the simulation to say, again, which one of these will make the biggest difference to change. The next steps for this work is to create a simulation model, simulate the effects of prioritized interventions, and then future grants would actually try to develop and test those interventions. But we're hopefully about to get an R21, R33 that's gonna mimic this for PrEP uptake in North Florida, which is extremely low. And so we'll be doing a similar process with young. We haven't decided if it's gonna be all sexual minority men. The Panhandle of Florida actually has some of the highest percentages of women with HIV. And is primarily Black and African American. So we'll have to decide, but it's gonna be basically in collaboration with community partners and youth partners. We're gonna be developing these maps and doing similar things with PrEP uptake as the centralized target. So that's my overview. Thank you. I think there's 2 or 3 minutes if there's any more questions or comments. Thank you. Oh, yeah.
Did anyone else? I'm
No.
one of the presenters, so I'm trying to be quiet. The methods that you were presenting at the end there.
The
are
system
really-
science.
Yeah, it's really interesting, and I'm just wondering like how within that things like racism were operationalized. I'm thinking again about Lauren's comments earlier and how there's like maybe many different dimensions of how you would conceptualize racism and how it applies to different groups like anti-Blackness as opposed to other forms of racism, or how it would intersect. And obviously, I'm not trying to make your study.
No.
building
So,
it
I mean, for
complicated.
well, first of all, we did pick Black and African Americans, period. So we didn't try to attempt people of color broadly. And in where we live in North Florida, there isn't quite as much variability in different ethnic backgrounds of Black and African Americans. Like it's pretty much, like I said, the deep South. We don't have quite as much. But I mean, we do have some Caribbean still. But anyway, we at least focused on one thing. And man, I'll tell you, it's been really hard work because providers don't use that word racism. Like they just have such a, and the group leaders were 3 Black women. And the kinds of racism that the providers were expressing was just like, Black people this, and like they don't even have a concept that it's inappropriate in any way. Like it's just so ingrained. So, we don't define it as a thing, we're defining it based on all the different factors that are coming out, if that makes sense.
Okay, and then like that context for the focus, I
Yeah.
missed that if you said it, so that's really.
I probably was rushing through, but no, I appreciate the question. And we did, people asked us about why only this or why, it's inevitably the question that keeps getting asked. But we felt that if you're addressing racism, like we had to focus in on, at least in our communities, one group and also the group that was most impacted.
And I will say, just to validate you, I've had the same experience of doing research with providers, and they say racist things right to your face, they tell them themselves, and then when you come back, even with just a summary where you don't say you specifically, but you just say, we heard things from providers that were problematic. People lose their minds.
We had to do,
Providers might be racist.
now add to that what's happening in Florida, where we're not even allowed to now we're actually now protected. The Board of Governors has taken research out of the equation. So in the name of research, we can do whatever we want. Mostly. But, right. But, trying to even get, sites on board to do this work in the context of, this kind of fear was extremely difficult. So we did have to, for example, we never talked about racism. We talked about anti-racism. Your group is at the forefront of developing anti-racism. Like we could, we had to be really cautious with how we framed what was going on. But, the community, we didn't have to. Just everyday stories. My mom makes sure I wear extra special clothes when I go to the doctor's office so that I'm treated this way. And, just story after story after story. Yeah. And then we also did what we called historical interviews. So we actually, in terms of community members that had a history of what this was like, about not being allowed to walk through the front of the hospital in the 70s and 80s. This is what we're, talking about. This is like still very recent for people. So those are some of the things that we're exploring, but it's a lot of work, but we're a group, right? So if every one of us could tackle one little part of it, maybe. I just love system science because it's the only method that I've come across that really tries to get at the whole picture as a system. And that was just really, really important to me because everything else I've done has felt very linear.
Yeah, thank you for expanding on that.
Yeah, thank you for asking. All right, feel free to grab me. Thank you, guys. Hey.
Right, so we have a 10-minute break. Oop, I left my phone here, but can somebody tell me the time? 2:18, great. So we'll be back at 2:30. Thank you, everybody. And don't forget that we do have the equity exercise in the back with the Post-it notes, so please feel free to jot some things down. Let's see. This.